हाँ सौरभ जी, आप करें या ऋतु करेगी?
Good morning, everyone. We are live on 96th session of Roundtable, and the topic for today is Standard for Care. I would like to invite Dr. Kalra to invite the speaker and the chair for the session. Dr. Kalra is the former CEO of NABH, and Ritu will take over for the meeting in terms of Zoom.
Thank you. Good morning to all, and welcome to this 96th session of Dr. KK's Heart Care Foundation of India Roundtable Expert Group Meeting weekly session. Before we come to the topic, I will briefly just give update about the COVID without any slides. Today time is short, and then Dr. myself, Dr. Aarti Verma and Ira will be initially speaking about the topic, and then for question, answer and discussion after that. So coming to the COVID situation, as such in India, definitely the third wave is on the decline. And the last 24 hours, less than 2 lakhs, total new cases 1,69,394, and 1,072 deaths has been reported. Death rate has come down from 1.33 to 1.19%. And India is in the world number third in number in relation to the COVID deaths. US reported almost 9.20 lakhs deaths, Brazil 6.3, and India since 4th of this Feb, almost 5 lakhs deaths have been reported. Kerala still continues to have cases. On last 24 hours, Kerala has reported 38,684 and 595 deaths. Karnataka, definitely compared to last 2-3 days, has slightly downtrend in this 24 hours, 14,950 cases and 53 deaths. Delhi has reported only 2,272 in the last 24 hours, new cases and 20 deaths. And infectivity rate is now come down even below 5%, that is 3.85% in the last 24 hours. And active cases are less than 12,000. As per Health Ministry report, the 2 doses of COVID vaccines are effective for preventing deaths in 99.3% of COVID patients. And 65% of the children in the age group 15 to 18, in the first month after starting the vaccination for the children, 65% of the children in the age group 15 to 18, they have received the first dose. And total vaccinations in India is almost 1.68 crores. So this was about the COVID situation. Even Delhi has now further eased out the restrictions imposed. Even schools are going to open. All the teaching institutions, colleges, schools, from senior schools are going to open from Monday, and from 14th, even nursery onwards, nursery to 8th, school classes also, schools will be open for these small children also. Now over to Chair Dr. Jamkar to invite the speakers. Dr. Aarti, just to introduce, is Vice President Medical Quality in Max Healthcare Group. She is taking care of the quality in healthcare across all the branches of Max Healthcare Groups. And Ira, she is an advocate. She is a legal advisor to Heart Care Foundation of India. Over to chair now, please.
Thank you, Dr. Kalra, for inviting to chair this very interesting session. I think we need to just introspect ourselves in overall standard of care across all hospitals, including bigger hospitals as well as the smaller hospitals, because that is some of the area where people are not happy. And that, suppose we have a documented evidence that we are following a standard of care, that will solve and create a more smoke screen between patient and doctors. So I just don't want to come between the knowledgeable session. I just will invite Ira to deliver her talk. Thank you.
First, I will be speaking. Then
Yeah.
then Aarti and then Ira are in between.
Okay.
Will see. Ira will come after me myself.
So I will correct myself. So I'll request Dr. Kalra to start this session. Thank you.
Thank you. I think screen is visible to all.
Yes, sir.
Yeah. So standard of care, which is a very, very, I will say, discussed topic. And we cannot differentiate standard of care when we are discussing about the standard of care from medical malpractice or negligence, because all the standard of care concepts, they come out of legal cases, because not only in developed countries, even in India now, there are a lot of litigations and they are on rise. And all these things, standard of care, when we talk, the advisories and guidelines and from time to time, various definitions or concepts are being provided or given by legal system, whether it is India or it is in the developed country, including US and UK and other countries. So the main objective of standard of care is to provide the working physician with a practical and useful model of standard of care to help guide daily practice. Special reference to the physicians or the staff in the emergency department, because patient safety is a concern. Is the harms to the patient which leads to, or so many other factors which leads to the mistrust and a lot of litigations. That's why standard of care becomes very, very important. No definition of standard of care exists in the legal system except the guidelines and advices issued from various courts, high courts or supreme courts in India, as well as in other developed countries also. The courts which have been modifying are giving various definitions of standard of care. So as earlier I said, we cannot differentiate, we cannot talk standard of care without talking about something, understanding the medical negligence or malpractice. Every physician, or especially the emergency physicians, should be aware of these various landmark cases that define the standard of care. Ira will be talking in detail about those things. Negligence in journal is legally defined as a standard of conduct to which one must conform and is that of a reasonable man under like circumstances. In law, medical practice is considered a specific area within the general domain of negligence. And we all will know a negligence requires 4 conditions or elements to be met for the plaintiff to recover damages. These conditions are duty, breach of duty, harm, and the causation. It's the second element, breach of duty, which is synonymous with the standard of care. Emergency physicians are on the front line of medicine and are frequently involved in medical malpractices. This is a US data. It is estimated and quite old data. 7 to 17 malpractice claims are filed per 100 physicians every year. The courts have frequently upheld that standard of care is what a minimally competent physician in the same field could do in the same situation with the same resources. Clinical practice guidelines are being used more frequently in court cases as support for the standard of care. However, their acceptance and uses are continuously changing and decided on the case-to-case basis. Historical development of standard of care varies definition from time to time. Initial definition as given by the legal system was based on custom. Means what I typically done, which is considered standard, a group of professionals in the same specialty, how they treat or manage their patients, that was considered as customary. And deviation from that customs were probably responsible for other unsatisfaction or the whatever we can say litigations which can arise out of those. Then in the 20th century definition under this case, that which is customary done plus anything that seems reasonable, if not typically done. It means reasonable word was also added in the customary approach. And the modern definition given after these court cases were considered, that which a minimally competent physician in the same field would do under similar circumstances. So it is not a perfection or very high knowledge or a skill. It's only a minimal competent physician will exercise in the same field would do under similar circumstances. Because standard of care in a tertiary hospital in urban metros, most advanced area, cannot be compared with that of a facility, a basic district hospital or a primary health center in a rural areas, where the technology, the expertise, everything will differ. So custom or reasonable action, whether is also very become important, that a custom was reasonable and whether the deviation from this custom was so unreasonable as to cause the harm. Now, who defines this? What commonly is done, means customary, may not be enough. That there are some things that may not be standard but are still reasonable for a physician to perform. A case example was a glaucoma patient in a young age group. Normally, initially, it was by custom, a young patient, especially below 40, the intraocular pressure studies were not done routinely in every patient coming to an eye physician. Then in one case, a young adult had glaucoma, and which was missed because this eye, the intraocular pressure was not done, and there was a harm to the patient. After that case, this thing again confusion arose. Means as a customary, whatever is done, we still do something more reasonable if required in patients. Standard of care is not met when the defendant, means physician, fails to exercise that degree of skill, care, and learning processed by other person in the same profession is exercised. Then who defines the reasonable care? Is the legal system defines or it's a medical professional? Standard of care does not mean perfection in practice. So these are some of the observations or the advisories given in the court cases which are being reproduced here. Medical malpractice is a legal fault by a physician or a surgeon. It arises from failure of a physician to provide the quality of care required by law. When a physician undertakes to treat a patient, he takes on an obligation enforceable at law to use minimally sound medical judgment and render minimally competent care in the course of services he provides. A physician does not guarantee recovery. A competent physician is not liable per se for a mere error of judgment, mistaken diagnosis, or occurrence of an undesirable result. From a physician's standpoint, that law only requires the minimal competence. The care does not even have to be average, which makes sense. Otherwise, 50% of all the medical care would be malpractice by definition. Medicine is an inexact science. This is not a mathematics. And generally qualified physicians may differ as to what constitutes a preferable course of treatment. This is generally seen two different experts or specialists in the same field may have a different approach or their opinion may slightly differ. Such differences due to preference do not amount to malpractice. Because these things are very, very important to understand before we start discussing about the standard of care. Now, clinical practice guidelines and standard of care, their relationships. Several court cases have addressed the use of the CPGs, or clinical practice guidelines, and currently there is no set standard for how these documents are used in the court cases. Some courts allow more liberal use of CPGs, and others require more scrutiny as to scientific validity of these guidelines before it is admitted. Normally, a document like a CPG would be considered hearsay in the courts. They are not considered as a clear-cut evidence. It's a hearsay basis. It is sort of a circumstantial evidence. It is taken as that. As the author is not available to testify or to allow for cross-examination. However, the court's case dealing with CPG use have suggested that if guidelines are of some scientific validity, that they may be used as a learned treatise and bypass the hearsay rule. CPGs may be used to lend credence to an expert witness, to impeach an expert witness, to defend a physician for following the document as the standard of care, or to suggest physician deviance from the document as deviance from the standard of care. So in the end, an explanation by an expert as to why a CPG is indicative or not indicative of the standard of care goes a long way in the court cases. When one side uses a CPG in a court case, it is up to the opposing side to ensure that jury is given adequate explanation as to why this may or may not actually represent the standard of care. This is a continually evolving topic and currently dealt with on case-to-case basis. Now, recognizing the complicated issues that arise with the formulation of CPGs, it would be seen optimal that committees who develop these guidelines should allow flexibility, include multiple sources of scientific merits, and not be dependent on the opinion of a relatively small panel. In addition, if clear evidence is sparse, this should be openly acknowledged in the formation of these guidelines. So far, I think these things will be dealt by IRA. I will skip. So basic feature of medical negligence and standard of care. To comprehend the scope of negligence, it is important to understand the scope of duty imposed on a doctor or a medical practitioner. A doctor or a medical practitioner, among others, has a duty of care in deciding whether to undertake the case or not, duty in deciding what treatment to give, duty of care in administration of that treatment, duty of not to undertake any procedure beyond his or her control. And it is expected that the practitioner will bring a reasonable degree of skill and knowledge and will exercise a reasonable degree of care. So these things are very, very important when we come to the standard of care, understanding that and how to develop that. So line between, I will skip all this. I think Ira will be talking about these things. Even in US Information Institute, in standard of care is an essential concept in determining whether a person was negligent and potentially liable for a tort. So standard of care is a degree of care, skill, or diligence which is reasonable and prudent man is required to use in particular situation in order to avoid the imputation of negligence. Duty of care requires in each particular case will depend upon the magnitude of the risk involved, the importance of the object to be attained, and the practicability of precautions. The standard of care required is a matter of law and does not vary according to the individual, although it does vary according to the circumstances. So how to ensure standard of care is exercised? After talking about that much complex, it's definitely very complex process. Standard of care is very, very complex concept. So how we can ensure in every hospital or a healthcare facility or at individual level, we can ensure the standard of care is exercised by all. So this is by way of improving the system and processes, by way of healthcare quality standards, accreditation standards, voluntary, which may be a voluntary like NABH, JCI, Australian, Canadian, etc., and so many others, government, national quality health standards, the India IPHS, Indian Public Health Standards for various categories of health facilities, even Clinical Establishment Act, or even the education regulatory bodies like Medical Council of India. There may be some beside these, there may be a regulatory or a mandatory requirement like fire safety or requirement of some other biomedical waste management authorizations like those other things. And various standard treatment guidelines which has been developed under the Ayushman, the Pradhan Mantri Yojana, Ayushman. So these are the various ways. Then accreditation system of a healthcare institutions and professional can ensure or facilitate standard of care is exercised at every level. Under this standard, I will coming to the standard treatment guidelines, which are generally considered as a standard of care. This has been a set of almost 1,572 procedures have been developed under this Ayushman Bharat scheme, healthcare scheme, with the help of ICMR. The idea behind having the STG is to have standardization in terms of treatment and promote effective and efficient treatment options. And from that booklet, I can say this booklet, the standard treatment guidelines under Ayushman Bharat, a minimum standard of care is needed by every individual seeking medical treatment in healthcare facilities, like that. So overall, in various specialties, 24 specialties, 625 standard treatment guidelines, and 1,572 procedures have been covered so far. It is a evolving process. More and more guidelines are being added to this booklet. Thank you. This was a basic concept regarding the standard of care. Now I'll request back to chair.
Yeah, thank you. I think it was Dr. Kalra. It was very elaborate, sensitizing introduction. We have question immediately or at the end?
So at the end, I think Ira will now, you can invite Ira first, then final comments by Dr. R.K. Verma.
But by the time the question becomes stale, so why not Dr. Gupta ask you one question?
Yeah, please.
I have to leave in next 2-3 minutes time. I just wanted to, because it's a wonderful presentation. I got two very pertinent questions. Being a governor of Medical Council of India, we have a situation. I will just narrate one of the case which is well known to everybody in Delhi, that a foreign graduate undergoing internship at a hospital, he was made to give intracardiac injection in a very critical situation under the guidance of anesthetist who was also resuscitating another patient. And then the patient's relative claimed that he was not entitled to do any treatment why he was given in the hospital. It's a well-known hospital in Delhi, I'm sure you all know. So that situation, the hospital had to undergo so many litigations and this thing. In a situation, emergency situation, what is the standard of care? Second issue which I have faced also, in a super specialty hospital setup, is a general surgeon allowed to do surgery like hypospadias when you have a pediatric surgeon, neurosurgeon and everybody available, and this general surgeon, although he has done an excellent job, he was sued by the family and the insurance company. So what is the minimum standard in a situation like emergency and this thing? Because I had to leave, I'll join you from my...
So as per the standard guidelines in the Ayushman, under Ayushman Bharat, they have defined for a particular procedure who is the qualified person, what are the minimum essential requirement and desirable requirements.
Yes.
It is already procedure-wise defined into that guidelines.
Yeah.
That is applicable for all kind of a situation, whether it is an emergency or it is a routine. Actually, guidelines, I have gone through these guidelines. To begin with, it is a good initiative, but I find even I can show you one of the, just I will show, this is one guidelines under Ayushman Bharat for severe anemia. They have given the name of every guideline, they have followed this procedure. They have given the severe anemia, the rate approved under the Ayushman Bharat, then average length of stay they have given for every procedure. In this case, severe anemia, they have given 3 days. The minimum qualifications of the treating doctor, MBBS, essential, desirable, MD and DNB equivalent, general medicine or a pediatric medicine. Then they have given a disclaimer, then they have given objective of these guidelines, then clinical key pointers. Some physical sign and symptoms they have enumerated in these guidelines. And then because these guidelines under Ayushman are insurance based on the insurance claims, to authorize or to give these claims for reimbursement of claims, with that nature, they have framed these guidelines to be used by all the physicians under these schemes who are treating this Ayushman Bharat patients. So then they have given some detailed laboratory parameters. They have not given, only they require CBC and HB report only in case of a severe anemia. If something beyond that, if bone marrow biopsy is done or some other tests have been done, whether that will be reimbursed or not, I'm not sure. Because this is a what treatment guidelines under Ayushman Bharat, which has been developed in collaboration with ICMR and a group of experts. I just one guidelines I have shown you.
Dr. Kalra, there are some NRHM guidelines also.
NRHM, they are same. they are also on the same pattern have been developed. First of all, this is a first initiative. When they will, I have seen American guidelines, especially I was seeing only yesterday for some diabetes. The American Diabetic Association, they have developed, there's very huge, exhaustive document available compared to the our guidelines given in the Ayushman Bharat.
No,
So they need to be updated very frequently, regularly. So now,
sorry, my concern of quoting these two examples, they had to fight almost 6 to 8 years from all levels of code to MCI and other thing to get clearance. I mean, both those cases are well known to everyone.
Yeah, I agree. I think Ira.
Okay. Thank you, Dr. Kalra, and thank you, Dr. Gupta. I'll invite Dr. Ira. She's going to talk on quality of healthcare, and she's Senior Vice President, Medical Quality, Max Healthcare. I think is the right expert to detail on all these areas of important topic. So, Dr. Ira, please.
Actually, thank you so much, Professor Jamkarji. But you have actually reached the profile of Dr. Aarti with me.
No, she wasn't there.
I'm a lawyer.
Anyway, no, thank you. Sorry about that. Yes. So, Dr. Aarti Verma, please start. Dr. Verma, you are not audible. Unmute yourself.
Yeah, good morning, everyone, and thank you for the opportunity. It's an honor and a privilege. I think Dr. Kalra has very comprehensively and in a very lucid manner, brought out the context of the standard of care from a legal perspective, how it is interpreted, as well as from a clinical perspective. So I don't think I need to go into those details. However, I'd like to definitely reinforce, as Dr. Kalra has suggested, that accreditation as a tool and as a framework is a very useful framework to introduce and bring about change in practice to standardized treatment in hospitals. And some of the as we know, I'll just refresh, we have 10 chapters in the accreditation standards of NABH, and we have 84 standards in these which are covered, and over 651 objective elements. And out of these objective elements, there are, at least 30 to 40% of them do refer to standardizing the way we do our practices. Of course, they talk about, supportive processes in clinical care as well as direct processes. And in one chapter, that is the care of patients, there is a very explicit standard that requires hospitals to follow clinical care pathways as well as clinical guidelines, which actually allude to standardizing the care. So I think the benefit of doing this, as per the Joint Commission of Joint Commission International, which is a very well-reputed, validated, acceptable organization globally, that this is a very important aspect of care. So what are the advantages according to Joint Commission is that they clinical practice guidelines, they standardize your care processes. So for instance, in an organization, say, which has 20 hospitals and 20 emergency centers, now anytime a patient comes with a chest pain or a heart attack, acute MI, how the frontline doctors and nurses manage the care of that patient uniformly across every emergency department. And the kind of care that is given is actually evidence-based. It is current, it is updated, because newer treatments keep happening, is the way that it is going, is the value that it is going to add. And further, when you are using clinical practice guidelines, you are reducing your risks. You're reducing your litigation risk as a last outcome, but you're reducing your risk of deficiency in any form of care to the patient. You're providing the best possible care to the patient. So your risks are reduced. And clinical decision steps are very easily memorized and or available through the computerized electronic medical record. So the doctor, the junior doctor, the senior doctor, the nurses, they have very good clinical decision steps available to them to follow those pathways very easily in there when they care for the patients, whether it's a Sunday or it's a night duty or it's a day duty. And then obviously the care is then provided in a timely fashion, because the clinical guideline may say that if a patient with chest pain comes, you need to do an ECG within 10 minutes because the heart muscle is going to get damaged if you delay this treatment. So the timeliness of care is also ensured when you where the clinical guideline is relevant to time, where time is a critical factor of care. So it ensures timeliness, and it is also helping us to use resources efficiently. So in our country especially, and not just our country, all over the world is grappling with how to meet the healthcare expenditures. So when we are using clinical practice guidelines, we are ensuring a certain degree of efficiency of and utilization of the appropriate resources. We are not overdoing care. We are not underdoing care. These both things are very important. Unnecessary use of additional tests or prolonging the stay of a patient or doing a procedure when it is not indicated is a very, very valuable outcome of standardized care. So I'm a very big proponent of accreditation, because otherwise you are, swimming in the dark and you don't know where to begin. If a hospital starts adapting accreditation as a tool to improve their standards of care, everybody does it uniformly. And both NABH and Joint Commission International are fantastic tools for this. They cover all clinical departments, whether it's the blood transfusion department, whether it's obstetric care, whether it's emergency, pediatrics, the transfusion of blood and blood products, transplant, kidney transplant, anything, each and every clinical service gets covered. And the better part of the other added value that accreditation provides is that the hospital also has to audit and see how the compliance to these guidelines have been managed in their hospital, and use that as a learning opportunity. So, okay, this is a guideline which is a reference. You have implemented it in your hospital. Have you really done it in all the patients? Were there any challenges? Was there any learning gap? Was there any training gap? So we have to continuously audit our processes and our guidelines to see our compliance, whether it is matching the best evidence or not. And if there is any outlier, accreditation stimulates and promotes a non-punitive environment. We do not like to call everything negligence. We have to be continuously learning and continuously improving ourselves. So another key factor of benefit of accreditation is that you are mandated, you internalize the learning in your organization. It becomes part of everybody's DNA to take feedback, to review your medical records, to review and audit your processes, to see how effectively you have been able to implement a standard of care at the point of patient care, not just in theory. It's not just a paper lying anywhere. So, and this is, hospital-wide, country-wide. So I think, there can be no less emphasis that using standards of care are very, very valuable, and using accreditation as a framework to enable the hospital leadership as well as the frontline staff to implement it effectively is a fantastic tool. So I think I will conclude with that because everything else, the detailing has already been covered by Dr. Kalra, and we will give our expert Ira some more time on the platform to share her views on this. Thank you very much.
Dr. Jamkar, I would like to come in, if you allow me, before Ira comes in. I'm sure Ira is going to give us also a very good insight. As I would have to leave, I just want to stress the point which Dr. Aarti mentioned. It is very important. you see, like, instead of patting your own back, it is always good to get external auditors to audit you, to ensure that you are able to comply with the standards which are globally, not only globally, but also at the national level, which is existing. And unfortunately, our courts in the country do not look at these dimensions, because most of the time they are not aware about these issues. So it is very important for us, and especially people like IRA, to bring it to the notice of the courts when there are negligence cases or there are deliberate act of negligence where standards are being compromised or quality is being compromised. So we have been always talking to the government to ensure that it is made mandatory in terms of accreditation, which Dr. Aarti mentioned. And we also wanted to ensure that there is an easy process of accreditation so that it is not long pending, very cumbersome and tedious. So without, of course, compromising on the processes and systems, but there should be multiple agencies attached with NABH or JCI and all, who can expand their horizon or their reach in our country, which is today missing. Like most of the hospitals have come back to me who are not NABH or non-JCI. They've all come back to me saying that it is very cumbersome, it is very long drawn, it takes a lot of time, it is very expensive. So we within QCI has been always trying to struggle to understand how we can reach out to people, how we can make more and more hospitals come under accreditation. And the last point is, I've always heard from the government, especially state governments, that, oh, we don't need any accreditation. We are holy cow, like government hospitals don't need accreditation. Now, this argument I don't accept. And that is where, we all have to put pressure also on the state government and the central government, that all government institutions must first set example of getting themselves accredited as per the standards, of JCI or NABH, which is made applicable in India, and not that the government hospitals do not or need not come under any kind of a audit or a kind of a standard which is made mandatory for patients to access. So this is where I would like to stop. And excellent presentation made by Dr. Kalra and Dr. Aarti. And Ira, I'll be there for a very short time, but I might have to leave in the next 3 minutes. So Ira,
before you leave, just I want to add and comment to what you said. It is very valid comment. I think at the juncture, we need to identify that all NABH standards are applicable at least to medical colleges under National Medical Commission. That Roy Chaudhary report, which became the National Medical Commission bill, where I was one of the members, we had added that instead of having a separate inspection process for medical college hospital, they should be NABH accredited. That automatically the quality of care improves. But now, because you are heading in insurance sector, where also standard of care has to be implemented, I think today's maybe proceedings, we can write down to a National Medical Commission about implementing NABH standards in all medical colleges under National Medical Commission. I think
you will be very happy to know that Uttar Pradesh government went ahead to get NABH accreditation for all the medical colleges in Uttar Pradesh. But we are struggling. The intent is good, but somehow it is not translating on the ground. It's taking a long time. Like in BHU hospital, I wanted to do NABH accreditation. Again, there is a resistance. It is not moving in that direction the way we expect them to move, with a clear-cut kind of a resistance, not to get audited, not to get seen by a third party. I mean, they take it for granted that whatever they're doing is the best. There cannot be anything better than that. That's the most unfortunate thing, Dr. Jamkar.
Yeah, actually, we were expecting a lot more better things after NMC takeover. But I think there is no change at all. They are just looking at same head count and space count and discount. Yes, and believe me, then nobody asks, do you teach? No question asked. Only thing they ask is, hidden ka office kitna, ye kya hai, wo kya hai. I think at least suppose we put that NABA standards, so at least they automatically they will set up and achieve those standards. I don't know when they will go and find out whether we teach. I think somewhere he has to say that whether we teach. We might have 1,000 say faculty available, but they are not teaching. And then obviously I find NAC far better for accreditation and evaluation than National Medical Commission. Thank you. I think with this question from Dr. Mishra, I will request Ira. Ira, I know you are not a doctor, you are a legal expert with ACFI. So please give your input. Thank you.
Thank you, Dr. Jamkar. And
actually, before you start, I have a basic very question.
Yes, sir.
All these accidents, they are happening, maybe some pediatric ICUs and burns in some ward everywhere. And then how come the doctors are responsible? They have not done anything. And they have never set up even the rules for who purchases, who buys, what are the standards, and who implements, who maintains. And then they are under behind the bar. So I've just failed to understand what is the legal background of all this. So I want you to answer this question in your talk.
So to answer your question, sir, this is actually a very valid question, and every day we are facing such problem. The basic problem is, sir, the doctor is the only person who is in contact with the patient. So the patient has a trust with the doctor, and the patient does not know who is behind the doctor, who is taking care of the management and everything. The biggest problem is this. Second big problem is the guidelines with respect to the standard of care. There is no such definition, and to be honest about it, not the Honorable Supreme Court, not any other court or lawyer is the competent person to frame any guideline with respect to standard of care in medical field, because we are not from medical professionals. We are just the legal professionals. So all the doctors or hospitals who are expecting the Honorable Supreme Court to come out with any guideline or anything, this is not possible. This is possible only by the doctors who are there in the industry, because you are the one who can actually tell us what is the standard of care, what are the guidelines, what is the procedure to be done. Yes, with respect to the accident and what you just asked me, it is important that we should bring the standard of care and all the guidelines should be there with respect to the hospital management also. Problem is that nobody knows about what is the procedure, what is the hospital management, what is the procedure happening in the hospital. Even as a medical lawyer also, I also don't know about many hospitals. So there are no proper standards for the hospital also. We only talk about the treatment protocols. We should also talk about the hospital management protocols. They should, unless and until those protocols, those guidelines are there, it will be very difficult for the doctors to come out and say that this machine was, this accident is not because of me, this accident is because of the negligence on the part of the hospital who have not complied with the standards mentioned in these guidelines. So here we should not, when we are talking about standard of care, we should not only talk about doctors, we should also talk about the hospital industry as a whole, how the hospital industry should work so that you as the doctors are saved from that point of all those accidents that happen. I have a very short presentation just detailing the important judgments, because most of the whole topic has been covered by Dr. Kalra in his presentation, and he has not left anything for me to speak, and Dr. Aarti also. So there are important judgments which only talk about the guidelines. The Supreme Court or the High Court or the National Commission, they are not the legislatures, first of all. So if we want any guidelines to be there and strict guidelines, then we need the legislature to come out and make it mandatory and implement it also. Like Professor Mishra said, and even Professor Jamkar said, that medical colleges are not ready to accept those NABH accreditation. So if we have to make it mandatory, then we have to make implementation at the root level so that everybody accepts those guidelines. And there is a standard. In fact, the word standard means it's standard for universal for everybody. But the problem is it is not there. And everybody expects the Supreme Court to say anything and then it will come. No, they can only give us guidelines. if we want to make the guidelines implemented, then we have to bring it in the legislation, make it a rule. Like if NABH accreditation is made compulsory for everybody, those guidelines become compulsory, those audits become compulsory, then yes, every hospital, every doctor have to fulfill it. Unless and until that happens, this problem will remain the problem ever. Can I have screen share?
Oh, you are allowed.
Okay.
You can share the screen.
Can you see my screen?
Yeah, but there's nothing. It's blank.
No.
Is it
Now it is
blank?
visible. Yeah.
Hit F5. Yeah.
Is it visible now?
Yeah, please.
Yes, yes.
So this is about why medical law, why these honorable Supreme Court has to come in place, why we are talking about standard of care, because there are so many number of medical negligence cases which are being filed against the doctors, and doctors are mostly ignorant about the legal aspects of their medicine, and they, in fact, the compensations which have been awarded by the Honorable Supreme Court and Honorable National Commissions are running in crores of money, which is the reason now this topic of medical legal and medical negligence, or the guidelines with respect to the standard of care, has become very important to discuss. So negligence, as Dr. Kalra has already discussed about it, is I'll only briefly say it's a legal duty to exercise due care. And what is due care is the topic what we are discussing right now. So if there is any breach of that duty and there is some consequential damage, then it amounts to any negligence. Medical negligence with respect to the doctors is a legal duty to exercise due care on the part of the medical professionals. Any failure to inform the patient of the risk involved, or the patient suffers any damage because of the undisclosed risk, and if the risk has been disclosed, still the patient would have avoided the injury, the breach of said duty would rise to actionable claim of negligence. It is very important to know that not all medical negligence are actionable medical negligence. So there is a very thin line difference between medical negligence and the negligence which is actionable. So actionable medical negligence is the neglect in exercising reasonable degree or skill and knowledge to the patient to whom he owes a duty of care, which has resulted in injury to such person. So the standard to be applied for adjudging whether the medical professional charged has been negligent or not in the performance of his duty would be that of an ordinary competent person exercising ordinary skill in the profession. The law requires neither the very highest nor very low degree of care and competence to adjudge whether the medical professional has been negligent of the patient. So what we are discussing over here is only about the ordinary skill. The standard of care is nobody requires that the doctor should have a very high degree of standard of care or very low degree of standard of care. It should be only of an ordinary standard of care. Some common errors which can lead to negligence are this, which I think I don't have to explain to the panel members over here because they are well versed about it. The standard of care is the care which any law expects from a doctor. The law does not expect the doctor to have a higher standard or lower standard. It should be a reasonable standard of care which any prudent doctor of his level will confirm. In PB Desai case, the Honorable Supreme Court in the year 2014 has come out with some guidelines to actually talk about standard of care and what is medical. To continue to treat except under certain circumstances when doctor can abandon his patient, to take reasonable care of his patient, to exhibit reasonable skill. So this is one of the important responsibility of a doctor, to exhibit reasonable skill. The degree of a skill a doctor undertakes is the average degree of skill possessed by his professional brethren of the same standing as himself. The best form of treatment may differ when different choices are available. There is an implied contract between the doctor and patient, where the patient is told, in effect, medicine is not an exact science. I shall use my experience and best judgment, and you can take the risk that I may be wrong. I guarantee nothing. Not to undertake any procedure beyond his control, this depends on his qualifications, special training, and experience. The doctor must always ensure that he is reasonably skilled before undertaking any special procedure or treating a complicated case. So from these guidelines itself, it is very clear that the standard of care that especially the legal fraternity is expecting from the doctors is only a reasonable standard, only an ordinary standard of care, the ordinary standard of procedure which any other doctor of his standing will undertake. We don't expect a very high standard, we don't expect very low standard. If we are expecting only the ordinary standard, which any reasonable doctor or medical professional of his standing will apply. Even if there are different choices, alternate treatment procedures are there, and the doctor adopts only one procedure, that does not mean that he has fallen down, that he is liable for any medical negligence. Similarly, in Malay Kumar Ganguly case, Honorable Supreme Court has specifically said no guarantee is given by any doctor or surgeon that the patient would be cured. So many times all the doctors come up and patients come up and say, doctors, hum theek ho jayenge. No, no doctor can give that guarantee. The doctor must undertake only a fair, reasonable, and competent degree of skill, which may not be of the highest skill. Adoption of one of the modes of treatment, if there are many, and treating the patient with due care and caution would not constitute any negligence. Failure to act in accordance with the standard, reasonable, competent medical means at the time would not constitute a negligence. However, a medical practitioner must exercise the reasonable degree of care and skill and knowledge which he possesses. Failure to use due skill in diagnose with the result that wrong treatment is given would be negligence. In complicated cases, the court would be slow in contributing negligence on the part of the doctor if he is performing his duties to the best of his ability. The biggest problem that every doctor faces is how to prove that the skill that he possesses, the treatment that he has undertaken on the patient is the reasonable skill he has done with the reasonable degree of care and skill and knowledge that he possesses. So for that only we require these guidelines to help us medical literature, the relevant medical studies that are available with respect to the particular procedure undertaken by the doctor. Because those are the only things that we can say and the court can understand that yes, no negligence has been conducted on the part of the doctor. In Kusum Sharma case, the court has come out with detailed principles while deciding whether the medical professional is guilty of medical negligence. Following well-known principle must be kept in view. So these are 11 important principles which in the Honorable Supreme Court has come out. And in this also, again and again, the Honorable Supreme Court has said that medical professional is expected to bring only a reasonable degree of skill and knowledge and nothing more, no, not the highest, not the lowest degree of skill is required. The medical professional would be liable only where his conduct fell below that of the standards of reasonably competent practitioner in his field. In the realm of diagnosis and treatment, there is a scope for genuine difference of opinion. And one professional doctor is clearly not negligent, merely because his conclusion differs from that of the other profession. The medical professional is often called upon to adopt a procedure which involves higher element of risk, but which he honestly believes as providing greater chances of success for the patient rather than a procedure involving lesser risk but higher chances of failure. Just because a professional looking to the gravity of illness has taken higher element of risk to redeem the patient out of his or her suffering, which did not yield the desired result, may not amount to negligence. Negligence cannot be attributed to a doctor so long as he performs his duties with reasonable skill and competence. Merely because the doctor chooses one course of action in preference to the other one, he would not be liable if the course of action chosen by him was acceptable to the medical profession. It would not be conducive to the efficiency of the medical profession if no doctor could administer medicine without a halter round his neck. It is a bounden duty and obligation of the civil society to ensure that the medical professionals are not unnecessarily harassed or humiliated so that they can perform their professional duties without fear and apprehension. The medical professionals at times also have to be safe from such class of complainants who use criminal process as a tool for pressurizing the medical professionals or hospitals, particularly private hospitals or clinics, for extracting uncalled compensation. Such malicious proceedings deserve to be discarded. So it is not that the Supreme Court or any court has not taken considerable view on the point that unnecessary complaints have been filed against the doctors and the hospital. We are very well aware of it. The Honorable Supreme Court is very well aware of it. And that is the reason they have come out with the reasonable degree of skill and care and knowledge to be performed by the doctor. Even in Nizam's Institute of Medical Sciences, Honorable Supreme Court has said the evidence in the present case has to be evaluated in the background of the above observation. It is clear that mere misjudgment or error in medical treatment by itself would not be decisive of medical negligence towards the patient, and the knowledge of medical practice and procedure available at the time of operation and not at the date of trial is relevant. So it is also important that many times doctors say that the medical profession, medicine as a science is an ever growing profession, science. So the procedure which has been conducted and on that day, what is the standard of care? That is the only important thing to be understood. If there are new treatments come up over a period of time and the trial takes 6-7 years and later then some new treatment is there, then that does not mean that the reasonable skill and degree has to be evaluated from the new available treatment procedure. There are legal remedies against which medical negligence can be filed, which is like filing criminal complaint under IPC, complaints before the respective state medical councils, consumer complaint, civil suit for the recovery of compensation, and alternate dispute redressals like mediation. Thank you. I hope this is the brief.
I think, Ira, it was a wonderful presentation, and because it was validated with all the Supreme Court cases, I think we have become a lot more knowledgeable.
Thank you.
And I think it was indeed wonderful. So, in order to see that we as medical practitioners practice without any pressure and without any prejudices, I think first thing that has to be done is we should be knowledgeable about our own rights. What caused negligence? Because most of the doctors, they don't know what is negligence. And then everybody says, to talk between the lines, the greatest enemies of doctors are other doctors. They talk in such a what you call it as nonsensical term, and it is what is called as unspoken language. Suppose you go to somebody, and the patient has been seen by me, and then the second guy says, "Arey, you have gone to that Jamkar." So what does it mean? So they speak an unspoken language as if, because everybody wants to just practice more, earn more, but it has to be a respectful way. I think doctors per se are the biggest enemy of other doctors. Anyway, I think it was a wonderful discussion. We are already crossed the time. So I will hand over proceedings to Dr. Kalra for.
I think it was a taken session.
Dr. Kalra, I just wanted to add something technology-wise.
Yeah,
that
please.
all these standard of care of all these guidelines need to be what is called as algorithm-based, and we should have what is called as the digital standards. So that suppose the patient history is there, and then there are some investigations. What you should do? You click, and it should go to the document where it should be done. Because otherwise you have to go and read, say, 30, 40 pages. So I'm just trying to put this idea of what is called the digital standards, so that it is algorithm based and it is easy to follow. I think that might be one of the idea.
Yeah, I agree. Dr. Rai, any comments you want to give?
This digital standards can come under the telemedical medicine guidelines.
Yeah. And even if it is a patient of say blunt injury abdomen pain, what should be done? And then there are some 10 findings.
Yeah.
So all these findings, what should be done? So instead of going through all that, it should go to the document required, where those documents could be validated, it could be upgraded, because we are, as you rightly said, we are in ever-growing science.
Yeah. I think, thank you, Dr. Aarti, Iraji, and Dr. Jamkar to chair the session,
Yeah.
and all the participants.
I just put some idea in chat box. Dr. Rajiv Joshi is one of the legal doctor expert in Pune. Has been fighting about all rights of doctors, about negligence and all that. And he has spearheaded the movement of starting an association of medical legal aid. And I put that Google form through your media. I just want to reach everybody who has been attending this session. And I will confirm with Dr. Rajiv Joshi that there might be few more applications. And I think Aarti and Ira should join this association.
Yeah.
Sure.
Thank you, everyone.
Thank you.
See you again
Thank you.
next week. Yeah.
Thank you, Dr.
Thank you.
Arun. Thank you, Dr.
Thank you.
Thank you, Ida.
Thank you,
Thank you.
Thank you, ma'am. Thank you, everyone.
everyone.